Map chercher, pas trouver. Map chercher, côté rouillé. Map chercher, pas trouver. Map chercher, pas trouver.
Baby, I don't wanna waste my time. Ken pa ge place pou moun ki pa prete. Anesthésie pour tout sentiment. Ki chita nan jere présence li passe. Bouquet souffri, bouquet nan kouri, bouquet bay tout moins sans pas joindre. Bouquet recommencer, pour manipuler, bouquet crier, on voit encore. Moi beaucoup, que moi encore, senti-moi flou. Les pensées c'est dernière fois. Ouais, l'amour, c'est d'oublier de faire ça. Pour arriver, jouer mon âme. Hello, côté rouillé, dans les critiques, t'avais cherché où. Hello, côté rouillé, dans ton temps. Hello, mon cœur pour moi. Marcher c'est pas pour longtemps. Pas marcher, c'est rapide, je vais accent. Royauté maintenant. Hello, moi je comprends. I'll put me first this time around. Can't let nobody kill my life.
Radio Groove FM. On ne recommence pas. On continue. Nous sommes sur le 87.9 FM et sur www.radiogroovefm.com.
Ou que t'as joué une nouvelle là, un par où, ou a bien roulé qu'on y est, m'dé tout ça. Chris Auto Hyper, une solution pour tout problème machine ou à baou, c'est problème mécanique, électrique et électrique. C'est qualité service nous baillons qui fait nous toujours être numéro 1. Visitez-nous une seule fois ou pas de regret. Notre Chris Auto Hyper, nous ranger n'importe quelle machine. Côté problème nan yé, n'a Titictel avec des appareils de dernier cri et un staff professionnel très accueillant. Belle locale, belle parking et nous avons qui peut aller chercher machine mais n'elle vient joindre Chris. Nous bail pi bon service à pi bas prix. Diagnostic, AC, heating service, tires, nous changer, nous ranger, brake service, oil change, nous répile moteur, nous réparer transmission et la trier. Chris Auto Hyper ouvre porte lundi pour le samedi 8h AM ou 7h PM. Visitez-nous, adresse 46 Grove Street, Spring Valley, New York, 10977. Contact 845 262 11 99. 845 262 11 99. Chris Auto Hyper, the best. Bienvenue à Size Restaurant, le meilleur restaurant haïtien à Nyack, New York. Vous voulez reprendre du bonjour pendant chita dans un bel espace? dans une atmosphère très accueillante. Une équipe professionnelle qui permet de sélectionner toute qualité plat haïtien bien élaboré par des chefs. Size Restaurant and Lounge. Pas de pression, pas de tension. Venez découvrir la délicieuse cuisine de Size. Grillot, fritaille, légumes, cabrite, du riz toute qualité. Bon lambi, ragoût, poisson, maïs et latrier. Un menu qui est toujours chargé, bien présenté pour satisfaire tout client. Size Restaurant and Lounge ouvrit mardi, mercredi, midi jusqu'à 8h du soir. Jeudi, 8h jusqu'à 10h du soir. Vendredi, samedi, 3h PM jusqu'à 2h30 du matin. Et le dimanche, midi jusqu'à 8h du soir. Size, c'est le restaurant qui a bien mangé, emporté et puis sans qu'elle sauter. Visitez Size Restaurant and Lounge et découvrir toutes meilleures saveurs dans le Caraïbe. Adresse 37 route 59 101A Nyack, New York. Téléphone 845 272 20 14. Size Restaurant and Lounge. Venez affamer, repartez satisfait et goûtez au cœur d'Haïti. Il n'y aura pas de mondial sans Groove. Et sur Groove FM, votre mondial est assuré. C'est l'occasion parfaite pour l'équipe sportive de faire vibrer les auditeurs au rythme des matchs à sensation. La 23e édition de la Coupe du Monde de football 2026, c'est l'affaire de Groove FM. Un événement à ne pas rater. Dominique Pierre, Enzo Boyer, Pierre-Richard Sidney, Roger Bissette, Franck Léna seront présents pour la retransmission des 104 matchs. 39 jours de joie et de passion. Les 48 nations sont réparties en 12 groupes de 4. Pour la première fois, cette compétition sera co-organisée dans 3 pays. États-Unis, Mexique, Canada. Et cette année, notre sélection nationale haïtienne sera présente. Nous pral matcher boule. Ce sera une ambiance sans pareil du 11 juin au 19 juillet 2026 sur Radio Groove FM 87.9. Sponsor Avomar. Téléphone 917 771 77 97. L'Amérique du Nord sera en fête.
Welcome to Food Fair.
Food Fair, c'est un market qui l'a poussé vite toute communauté. Yo vend bi bon produit, nan bi bon prix. Pas rentrer la caillou sans pas passer acheter dans Food Fair. C'est eux qui pi bon et c'est là on joue tout produit qui sorti dans pays tant pour Guatemala, Colombie, Mexique, Santo Domingo, Haïti, États-Unis, Équateur, Pérou pour ne citer ça seulement. Pour acheter sans besoin en gros ou en détail. Et puis, il y a un bicri kabao, bon gâteau, bon petit plat chaud que vous pouvez manger en dedans ou bien l'arrivée la caillou. Relais au Kounia dans 845 290 06 25 ou bien passer dans l'adresse 175 East Central Avenue, Spring Valley, New York.
Welcome to Food Fair.
Food Fair, c'est numéro 1.
Si Jésus, m'geti Jean, ti Marie, Josaphat, Elifet, hey, avantage ça.
Mais vous moi te parler sur tracassé. Chaque jour me dit tracassé, qui te joue là. Kounia, Meli. Tracassé, tant pis. Avant aller, dis-moi quand on met des canaux pour là oui.
C'est de parler, m'a de parler. Ou pas tant qui belle bagarre avantage à gagner dehors. Kounia, l'autre policier assurance n'a avantage. Ou ka mettre 600 000 avec vous pour seulement $50. Oui. C'est pour si toutefois bon Dieu t'a relé yon là-dedans. En tellement tout ka chanter sans problème, oui. Sans pas dans l'élément de prêter. Et même si moun nan ta en Haïti, avantage à chanter en tellement sans problème.
Ça ou dit me la tracassé pour $50 seulement. Avantage à payer, chante enterrement, tout le monde ça yo. Même si vous êtes en Haïti, c'est pas c'est pays seulement avantage d'une baille monde. Et bien tracassé. Bon, tout fait l'isque non, parce que m'ba vle faire zéro. Comment un petit joueur non quand même, parce que faut m'taper dans l'isque non ouais.
Si Joël, TIPO.
Merci.
Faina attendez toujours. Même si mon n'a vivre ici ou t'avez fait un terme en Haïti, avantage à payer transportation, à tout ticket avion, aller-retour, pour mettre moi, oui.
Oh, gardez pied, avantage à tirer sa base. En tout cas, relais avantage à tirer Konya pour pas faire zéro. 718 877 27 57. 718 877 27 57. Affaire paquet pour enterrement. Avantage pour faire ça sec. Bonne rebelle.
Si vous pas mettre bouche dans ça, petit nous yo a pris péri.
Ou besoin acheter un caille, ou bien ou bien caille là déjà mortgage ou 3 euros, Jean Volsi Mortgage Team a aidé gérer ça rapide avec Loan Depot. Jean Volsi Mortgage Team, puis bon broker qui t'a aidé on acheter caille et puis aider avec mortgage. Caille ou t'a rêvé gain longtemps, déjà non mais Jean Volsi Mortgage Team. Ça qu'arrivé ou pas te connaître comment pour te commencer pendant chercher tout côté. Ou bien bon formule là non mais on connaît. Jean Volsi Mortgage Team prend 100 € pour autant de haut et puis aider au réaliser projet Kaiwa. Jean Volsi, c'est seul conseiller hypothécaire haïtien qui apprend le processus Kaiwa vin plus facile pour 845 659 1445. C'est numéro de téléphone qui est disponible pour relayer, discuter sous prêt ou besoin fait pour Kaiwa. Jean Volsi, il y a une façon d'y aborder client Lio, c'est l'homme parfait pour qualité Kaiwa chercher. MLS ID Jean Volsi, c'est 94 74. Contactez-nous dans le numéro ça 845 659 1445 Jean Volsi à commercial loandepot.com ou bien passez dans l'office Jean Volsi Mortgage Team qui nous...
Radio Groove FM. On ne recommence pas. On continue. Nous sommes sur le 87.9 FM et sur www.radiogroovefm.com.
Moi gagne dans l'amour, sans doute tout laisser pour. On m'a fait mes yeux au côté cœur, pour toute folie, moi fait pour. Moi tourner, pas pour moi, mais baby pour ma gomme, pour c'est ça, moi, ouais. L'amour dans sa chimère, mais t'allais wap tourner, la go caché rêve, moi. Pas faut changer le moi. Cause I'm in love, like I'm in love, baby. I'm in love. Oh, yeah, I'm danger. Oublie-moi de m'accorder encore, t'es qu'un danger. Tellement beau, t'es trop plaisir avec mon danger. Si on joue à côté de ma chance, même si la vie change. Oh, elle est le danger, même si on fait pas. She might got this man good teeth. Oh, my God, this man texting you. C'est un coup de poing, ça fout le nage. On peut vivre sans nom, mais moi, nous ménage. D'amour et possessif, papa. On est bébé, mais regarde. Les deux, les papas, oh, la vie, mais. Fais-moi des mots, encore où t'es qu'elle le nage. Non, où t'es pas plaisir, fais-moi la nage. Fais-moi ma chance, même si la vie change. Soyez le danger, même si vous faites le nager. Où t'es prends plaisir à faire pour parler les dangers. Ma chance, même si la vie changeait. On parle les dangers.
Finalement, mettez-moi premier.
Finalement, bok mwen yo lase. Ou ban responsabilité. À chaque fois que ça mal passé, pourtant, c'est pas de fallait moins pas connaître tout ça. Ça y est, c'est remettre, pourtant, c'est pas de fallait moins pas connaître tout ça. Ça y est, c'est remettre, à toute perfection et sans validation. Remettre un coup, toute perfection et sans validation. Tout ça mien, tout ça posé, c'est bonté, pas de beauté, pour appeler mes dents.
And good evening, bonsoir tout le monde, and welcome to the Hana Health and Wellness Show on Radio Groove FM. Tonight, I am your host, Farah Fizeme. I'm here today to bring a very riveting topic for you today. Today, we are empowered to talk about lung cancer. We're empowering our communities with trusted health information that can save lives. I wanted to just bring out the best in us, and the best way to do that is to give you a little bit of information, right? Many people believe that lung cancer only affects smokers, but that's simply not true. While cigarette smoking remains the leading cause for lung cancer, also developing in people who have never smoked due to secondhand smoke, random gases, and other air pollution. Today, we have a great presenter, backed by popular demand. We've had it before. Brenneth, can you hear me?
I can hear you very well. Thank you so much for having me back. Can you hear me?
Absolutely. Please introduce yourself to our audience, and please share with them a little bit about you for those new listeners who might not have been here the first time you were here.
Of course, it's been a while. So my name is Brenneth Stalker. I am an advanced oncology certified nurse practitioner. I have over 17 years of experience in oncology in the New York metro area. I started my career at Memorial Sloan Kettering Cancer Center, and then I spent about a decade at White Plains Hospital as their lead nurse practitioner in the cancer center. And then I moved on to Johnson & Johnson, where I'm currently a oncology clinical educator, meaning I go around to different New York City healthcare systems and teach them about prostate, lung, and bladder cancer.
Wow. And I think the last time we did prostate cancer together, right?
Exactly. Yep. Awesome. And I think bladder's coming up soon. Yeah.
Yes. So we have plenty of good goodies for our patrons, and we are so excited to share this information with them. So let's start out slow and steady, Brennan. Let's understand the burden and disparities that lung cancer shares with the community.
Of course. Well, I think we often hear that lung cancer is the number one cancer killer. And that phrase in itself is a little misleading because lung cancer is actually the third most common type of cancer, but it is the leading cause of cancer-related deaths, meaning that it trails in the amount of people with lung cancer behind breast cancer and prostate cancer. But even though it's the third most common type of cancer, it kills more people than prostate, breast, and colon cancer combined.
Wow. Combined. What do those numbers
Combined.
sound like or look like?
Well, we anticipate in 2026 alone, something like 125,000 people are expected to die due to lung cancer.
20,000. Wow.
125,000.
Jesus, that's even worse.
Yeah, it's much worse. And, you know, that in itself is, I think, a staggering statistic. But know also that Black men have higher rates of lung cancer and are more likely to be diagnosed at a later stage than white men. And so the Haitian American or other Caribbean communities, we see the same pattern. We see a later diagnosis, we see lower screening rates. And I think a lot of that has to do with many barriers, like, different languages. There's an inherent mistrust of the healthcare system. And I think there's also a real cultural hesitation not to talk about illness or smoking history. And remember that the later stage of diagnosis, really like any other disease, right? The farther that disease has progressed, the more limited your treatment options, and overall, the worse your prognosis or your outcome of that disease. So that combination of factors really makes these early conversations and screening so incredibly important for this community.
Let's tell them what those numbers look like for those Black men who are dying in such vast numbers.
Sure. You mean in addition to that 125,000?
Yep.
Sure. So of those 100, well, I should say of those 125,000 that are expected to die in 2026 just due to lung cancer, it's hard to say when you break it out of, who, in terms of who exactly is dying, but we do know that of that 125,000-ish deaths, that's about 20% of all cancer related deaths, meaning that's why, of those other 80% or so, that's all the other cancers combined. But of all cancer related deaths, 20% are due to that lung cancer. And then within that, we know that only about 18% of eligible people that are eligible for screening, which I know we'll get into kind of screening guidelines and why it's so very important to be your own advocate. But those who meet our current screening guidelines, only 18% of folks are getting screened.
Wow. So that's not even a fraction.
Yeah, it's a very, very small fraction of the amount of people that could get screened and potentially get that lung cancer found at a much, much earlier stage.
Right. And we touched a little bit about risk factors. How would you categorize some of the risk factors for the population at large? And then we'll break it down into the people of color.
Absolutely. So, a lot of times, or at least in healthcare, we call lung cancer a silent disease, or that it has a silent nature. And that's because many people, they don't really go and seek help until they feel very, very sick. But lung cancer at an early stage often causes no pain. We don't have any nerve endings in our lungs. And unless that lung cancer is pushing on another organ, there may not be any obvious symptoms in terms of that lung cancer specifically. So, lung cancer itself happens when those healthy cells in the lungs just change and grow out of control. They then form these tumors that ultimately make it hard to breathe. But early on, most folks have no symptoms at all. If or when those symptoms do show up, they can include things like, persistent cough that doesn't go away. They can cough up blood. They might have some chest pain, some unexpected weight loss. They might get frequent chest infections like bronchitis, and they might get them recurrently, just over and over. Or they might feel very, very tired but have no flu or cold-like symptoms. So any of these, meaning it could be one of those things, it could be all of those things, but early on, you may feel absolutely none of them, but you still may have lung cancer. So because those symptoms show up so late often, waiting until you feel sick to see a doctor can be extremely dangerous.
Wow. So how late in the disease process in your sometimes does these symptoms show up?
I mean, you can have a patient come in that has stage 4, which is essentially, that the latest stage of disease, meaning that lung cancer has already spread to throughout the body. You can have a patient walk in with lung cancer at that stage 4 and have very little to no symptoms already.
Wow.
A lot of times, if we do catch it early and that patient has not, isn't eligible for screening or wasn't going for screening, but did happen to have symptoms, it's because of the placement of those tumors. Those tumors may be kind of inadvertently pressing on another organ, which then leads to a symptom, or just the location of that tumor, even if it's a very small tumor size, might be impeding something else, whether it's blood flow, to the heart, to the brain, but it's almost a secondary symptom. It's almost a fluke, depending on where or what symptoms that they have. Oftentimes, though, you don't have any symptoms until it's a much later stage.
That's very, very alarming. Wow.
Yeah, and we know that if lung cancer is found early, so in that localized stage, meaning that it's only within the lung, right? Before those symptoms appear, the lung cancer is really only within the lung. About 65% of people that have that localized stage at diagnosis are still alive 5 years later. That's because when it's found very early, it is highly treatable. When it's found after it's spread to other parts of the body, that number drops drastically to under 10%.
Wow.
So, yeah, this is why it's absolutely so important for folks not just to get screened, but to advocate for themselves, because you may not have any sort of symptoms. You may not even be a smoker, and you might have lung cancer that is progressing.
So not just advocate, but kind of like be your own storyteller to your doctor. So I know sometimes if the provider's not asking the right questions, especially in our culture, they're not going to get the right answers.
Absolutely. Absolutely. And this is something, you mentioned early on that it's not just smokers, right, that are at risk for lung cancer. There are other risks for lung cancer. Smoking leads to about 80 to 85% of all lung cancer related deaths and diagnoses. But the second highest leading cause of lung cancer is secondhand smoke. And so perhaps you're living with somebody who's smoking. Perhaps you lived as a kid with your parents who smoked all the time, and you've been around secondhand smoking for a very long time. That's the second leading cause of lung cancer. There are also invisible gases like radon, radon is something that I feel like we don't talk about enough as a culture, but radon is an invisible gas that's found in homes, and it is due to the breakdown of uranium in rock and soil. And what does that mean? Really, it just means that in any places that have any sort of mining, any areas that are doing major construction, that gas of that breakdown, thinking of rock and soil, if you are breaking through rock and soil, you're going to release this radon gas. It seeps into the ground and then it gets into our homes. And you'd think a highly congested area like New York City, right, with lots of traffic, and would have really high levels, but actually it's urban geology, and these kind of high-rise structures often result in lower indoor radon compared to kind of more rural areas. But those ground floor spaces, meaning the basement apartments and the first couple floors, can hit risky levels, which can make testing even more critical. And these numbers that I'm stating are nationwide published numbers, but also know that not all apartment buildings in places like New York City are required to test for radon. So of the places that have been tested, we know that in New York City, if we look at from a bird's eye view, that there are lower levels of radon in New York City. However, not all of our large apartment buildings are being tested. But radon testing kits are available through the state at no cost. You just have to go to the state website. You can actually get one sent to your house. You can test the radon levels in your home. If you have a basement apartment that you've turned into, a secondary space that you use all the time, or maybe you're renting it out, or maybe you live in a basement apartment, I urge you to do your own research and can absolutely tell you that there is free radon testing kits available to you at no cost. And if you do have a high level of radon, then there are things that you can do to, it's required for landlords if there's one detected, if there's high levels of radon detected, it's required for landlords to do something about it.
Wow, that's amazing. So who knew about radon that would be so caustic to someone's health?
Right. And as healthcare providers, you mentioned not being your own advocate, making sure that you are telling your provider about your entire history. These are things that we as healthcare providers, and especially those, in the healthcare system today, we are so pushed for time and have such lack of time that I can say that it's not always. I mean, I wish I did this with every single patient and went through their entire occupational history and things like that. But, you might have somebody come to you who's early, still a young person, right? 40, 50, 60 years old. And they tell you, oh, I'm a retired teacher, or I'm a retired, whatever. But they don't tell you that for the first, in their 20s, they worked in a mine or in some sort of industrial area where they were exposed to a lot of things and found their lifetime career a little,
Later
in
in
their
life.
in their later 20s or 30s or 40s even. And we don't always have the time, or we just don't always have the time to say, well, tell me, okay, you're a retired teacher. What did you do before that? Do you happen to have any occupational exposures? I mean, you just have to know as a patient to tell your provider this and be your own advocate, or maybe be the advocate of your loved one who doesn't mention those types of things to their healthcare provider.
Yeah. And I mean, we talked about radon, but what about asbestos and other work exposure?
Absolutely. Radon, we know is one of those that is almost another silent killer, right? We don't talk about radon enough, but yes, any of those substances that are found in the workplace that used to be commonplace, and especially in places with older buildings, right? Like asbestos, like arsenic. Those all have been directly linked to lung cancer. So if you have, or if you know that you worked in a really old building, if you were next to a large construction site, I mean, thinking about things like 9/11, there's just so many times in our lives where we're exposed to these pollutants. And absolutely that can lead to, especially if it was a long-term exposure, can lead to the development of lung cancer. We know too that things like family history doubles your risk for lung cancer if you have a first degree relative, meaning, a parent or a sibling with lung cancer, that doubles your risk of getting it. If you have had previous radiation to the chest, so say you had breast cancer at an, early-ish age, or even you had breast cancer 10, 20 years ago, and you've had no evidence of disease, essentially curative since then, just having had that radiation therapy to your chest can then lead to the potential of lung cancer.
Wow, I did not know that. Tell me more about that.
Well, yeah, I mean, we have lots of folks who have had radiation therapy to the chest for one reason or another, whether, it's a different type of cancer that could be cured essentially. And it is, again, a point of being your own advocate. Ideally, you would have a healthcare provider that then made sure that you were screened every single year following that radiation therapy, that you were screened every year for lung cancer. But then we run into insurance issues. Maybe you moved away, you have a new healthcare provider. Have you done a full comprehensive health history with that provider, et cetera? Or maybe you just think, I haven't, I feel great. There's no way I would feel lung cancer, wouldn't I? But like we said earlier, no, you would not always feel any sort of symptoms until it's often too late.
Wow, that's amazing. So you
It's
treated
scary.
one, and now
Right.
you put yourself at risk for something else.
Absolutely.
Just
That
trying to save
increases
your
your risk
life.
for another.
That's funny.
Yes. Yeah. It's
Wow.
scary.
And
And we have pediatric cancers. I have a very good friend who had pediatric cancer and just had to undergo a double mastectomy, because it led to breast cancer, not lung cancer. But previous radiation therapy, regardless of, leads to those changes in cells, which can ultimately lead to tumors. It does not always, of course, but it certainly can.
Wow. So, and I think risk stays elevated even after years of quitting smoking, right? I think we mentioned that earlier. Can you talk a little more about that?
Of course, yeah. This is where our screening guidance and guidelines get a bit frustrating, to be honest. So currently, we have this United States Preventative Services Task Force. That's this kind of governing body that comes up with our screening guidelines. And why that is so important is that depending on what their recommendations are, will lead to insurance and Medicare, Medicaid saying, yes, we will pay for these screening tests. So right now, in order to screen for lung cancer, you need what's called a low dose CAT scan or CT scan. And right now, those guidelines for screening for lung cancer are for people ages 50 to 80 who have smoked the equivalent of 1 pack a day for 20 years. And so they have a 20 pack year history, and we can talk more about that. But they have to be within that age range, 50 to 80, 1 pack a day for at least 20 years or more, and who currently smoke or have quit within the past 15 years. And remember, so that's a very small subsect of people, right? There are people younger than 50 who have smoked a lot more than 20 pack years, and they have not necessarily quit. Maybe they quit 16 years ago and they're only 40. I mean, it's a very small subsect of folks. And remember, even within that screening guideline, only 18% of eligible people are getting screened. That being said, studies have also shown that Black individuals often develop lung cancer at younger ages and after fewer pack years of smoking. The same is true for the Asian community. So these kind of strict guidelines can really miss these high-risk Black and Haitian and Asian individuals. And that's why us clinicians are really advocating to expand eligibility criteria, but it's very, very difficult to expand that United States Preventative Task Force, that screening guidelines, because they need a certain level of evidence, meaning they need a certain number of studies that have been done that show without a doubt, that show that screening risk needs to be in a wider range. And that, of course, would lead to a lot more cost to the healthcare system, to, the people, to the insurance companies, all of that. So right now, we are advocating for, we don't have the data to back it up, even though we know that folks like the Black and Haitian community are at a higher risk. We still don't have the screening guidelines to support it, which means that if you are outside of that screening criteria, you're going to have a hard time getting a provider to prescribe or to recommend screening and write you for a CT scan. And then you're going to have a hard time getting that screening test paid for by your insurance. And of course, that doesn't even, address the the fact of those who don't have insurance, of folks who are here without any sort of employment, or if they're any of our folks that are at risk for so many other reasons, essentially.
Essentially, those who are undocumented and don't
Yeah,
have any healthcare coverage is what you're getting at.
absolutely. Yes. And that, I mean, which puts you a risk for so many other things, of course, but regardless, those screening guidelines for lung cancer really do not encompass all of the folks that are at risk for lung cancer. And if I am a big proponent for saying that you are not married to your physician, meaning if you have a provider or physician that that maybe you don't meet that specific screening guideline, maybe you're 40 and you've smoked for 10, 20 years, or you've been around secondhand smoke, you're at high risk for lung cancer. Maybe you have a physician that says, no, you don't meet those screening guidelines. Go to somebody else, go to a different provider. That one person is not the end all be all, essentially, of what your healthcare situation should be. If you know that if you know you're at high risk or your loved one is at high risk, find somebody else. There are ways around, completely legally around these screening guidelines. All we need to say is look at you, listen to your lungs. Maybe you have a persistent cough that doesn't go away. And that in itself can change whether or not you are eligible for screening. But it's those little tweaks that you need to fight for and tell us, tell the providers about, to really fight for yourself and advocate for yourself to get those screening tests. And if we get them and we find that cancer early, your prognosis, your outcome is going to be much, much better. We know that.
It's amazing. So in a nutshell, early detection is the key to survival, is what you're saying.
Absolutely. Lung cancer right now is essentially a death sentence. I mean, like I said, if you have lung cancer diagnosed really anywhere but stage 1 or 2, you've got a 10% chance of survival, less than 10% chance of survival over the next 5 years.
Wow.
That is a staggering statistic. If we had wider ranges of screening, if we screened more folks, if folks were more aware of the risk factors for lung cancer and knew to tell their doctors, their providers about those risks that they have been exposed to, or that they, whether they're smoking or not, but if they advocated for themselves and we had better guidelines, we could catch lung cancer so much earlier, and we could change it from a death sentence to a livable disorder, or at least a treatable disease.
And when you tell our audience about smoking, sometimes they like to, I guess, put them in little boxes, compartmentalize them, that, this smoking's good and that smoking's bad. You kind of like tell them, like, all smoking's bad.
All
Whether
smoking
it's
is bad.
cigars, cigarettes, weed.
All smoking is bad.
Hookah.
Whether vaping or smoke. Yes, I mean,
Whether
technically vaping is not smoke because it's not combustible, right?
Mhm.
The problem with those kind of things is that we don't have enough data to support. Again, there haven't been enough studies to support, and by studies I mean, there's very strict criteria in terms of how you conduct a research study. And depending on whether or not that criteria is met, the powers that be, that, like powers like that United States Preventive Task Force, can say this is essentially high level of evidence or low level of evidence. We don't have enough studies worldwide to know that vaping itself causes the changes in the cellular structure of the lungs to then lead to lung cancer. But we know that inhaling pollutants causes it, right? We know, like we just talked about radon and asbestos and arsenic. We know for a fact that just breathing chemicals like that in causes what's called hyperplasia in the lungs. It causes those cells to change and ultimately can lead to those tumors inside the lungs. So whether or not you're inhaling, whether it's marijuana or, tobacco, or it doesn't matter how pure, it doesn't matter how, when you're inhaling something that isn't meant to be there, it's going to lead to changes in the lungs. And those
Especially when it's a
changes can
repetitive
ultimately lead to
active,
cancer.
especially when it's a
Absolutely.
repetitive action that's done daily.
Absolutely. Regardless, even, I mean, it could be very intermittent, but every single time that you're doing it, you're taking that risk of changing those cells in the lungs. And if you already have other factors that will lead to an elevated risk for lung cancer, that is just compounding your risk.
Amazing. We're going to take a quick commercial break and we'll
Oh.
be right back. Okay, Brennan?
Sounds good.
Awesome.
Welcome to Food Fair.
Food Fair, c'est un market qui la pour servir toute communauté. Yo vend bi bon produit nan pi bon prix. Pas rentrer la caillou sans pas passer acheter dans Food Fair. C'est eux qui pi bon et c'est là on joue tout produit qui sorti dans pays tant que Guatemala, Colombie, Mexique, Santo Domingo, Haïti, États-Unis, Équateur, Pérou pour ne citer ça seulement. Ou acheter sans besoin en gros ou en détail. Et puis, il y a un bécri ka ba bon gâteau, bon petit plat chaud que vous ka manger en dedans ou bien l'arriver la caillou. Relé yo kounya dans 845 290 06 25 ou bien passer dans l'adresse 175 East Central Avenue, Spring Valley, New York.
Welcome to Food Fair. Wholesale fresh market.
Food Fair, c'est numéro 1.
Ou besoin acheter un caille, ou bien ou gen caille là déjà mortgage ou 3 ou, Jean Volsi Mortgage Team a aidé gérer ça rapide avec Loan Depot. Jean Volsi Mortgage Team, pi bon broker qui ka aidé on acheter caille et puis aider avec mortgage. Caille ou t'a rêvé gain longtemps, c'est jamais mais Jean Volsi Mortgage Team. Ça qu'arrivé ou pas connaître comment pour te commencer pendant chercher tout côté. Ou bien bon formule là nan men konnière. Jean Volsi Mortgage Team prend 100 yo pour autant de ou et puis aider au réaliser projet Kaiwa. Jean Volsi, c'est seul conseiller hypothécaire haïtien qui apprend le processus Kaiwa vin plus facile pour 845 659 1445. C'est numéro de téléphone qui est disponible pour relayer, discuter sous prêt ou besoin fait pour Kaiwa. Jean Volsi, il y a une façon d'y aborder client Lio, c'est l'homme parfait pour qualité Kaiwa chercher. MLS ID Jean Volsi, c'est 94 74. Contactez-nous dans le numéro ça 845 659 1445 Jean Volsi à commercial loandepot.com ou bien passez dans l'office Jean Volsi Mortgage Team qui est dans 500 Airport Executive Park, Nanuet, New York 10954 suite 509. Depuis 2003, n'a pas bon service. Ou la caillou.
Chaque mercredi, sorti 6h pour arriver 8h du soir, Hana, Asian American Nurses Association of Hudson Valley, New York, a invité à suivre une belle émission qui relève Health and Wellness sur Radio Groove FM. Dans l'émission ça, nous pourrons parler de la santé, nous pourrons parler de toute qualité maladie qu'on a gagné et bon conseil qu'on mérite. Pour participer avec nous dans une belle émission ça, Health and Wellness, relève dans 845 419 1825 ou cabrecher nous sur App Radio qui c'est Groove FM Radio, sur Tuning, sur Groove FM Radio et sur 87.9 FM. Health and Wellness, chaque mercredi, 6h, 8h du soir, sur Radio Groove FM. Nous, c'est Hana. Santé ou, c'est priorité. Nous.
Hana pas jamais découragé. Hana t'es campé, pilité contre COVID-19.
And we are back. So, Brennan, we were knee deep in lung cancer. Very scary stuff going on right now. Just to give a quick recap to the audience, right? I'm going to say it in Creole, Brennan, so bear with me.
Perfect.
Okay.
Of course.
So, Brennan dit nous comme ça, son nurse practitioner lié, li travaille principalement dans le domaine cancer, là, principalement bladder cancer, prostate cancer and lung cancer. Li dit que cancer de poumon, c'est plus gros cancer qui gagne, c'est troisième plus gros cancer qui gagne. Et puis, mais c'est lui qui premier cancer qui tue plus monde. Il dit, on estime de 125 000 monde qui doit mourir avec cancer de poumon en ça en 2026 là. Il dit, en plus de ça, dans 25 000, non, 100 025 moun sa yo, moun de noir, spécialement garçon noir, a mouri plus, peut-être à 20%, nan yo ge doit mourir avec cancer de poumon. Il dit, et puis nan ti 20% ça, simplement 18% moun éligible pour yo prendre screening, pour yo al tester pour connaître si yo peut-être yo ka gagner cancer de poumon. OK? Il dit que c'est pi bonheur c'est grand matin, il dit c'est de pour tester pi bonheur ou gen plus chance à traiter et survivre vie maladie ça. Il dit depuis yo ka joindre et cancer là dans stage 1 à bien 2 ou gen ont plus grande chance pour vivre plus que 5 ans après yo fin traité. OK, mais si c'est dans stage 3 ou bien 4, ou gen 10% chance à vivre 5 ans après yo traité. Li dit symptômes yo gen doit pas même jamais symptômes, c'est ça fait ou pas doué tant c'est log symptômes pour al ka docteur pour tester et traiter. Li dit que de pour gon histoire de fumer que te mette pas ou même qui t'a fumé hein, gen doit c'est ton famille ou même kon songe moi même vividement comme ti moun tout garçon dans famille te fumé papam tout mon oncle moi même gen mon oncle moi un peu de madame yo te fumé tout monde fume, ça veut dire que yo t'a fait belle petite fête et salon yo bien dans basement yo tout monde a fumé une cigarette. So ça veut dire que moi même peut-être pas m'exposer à second hand smoke kounya m'gon l'autre bagay mal parler à docteur non. So it's very important. Très important que tester. Les des symptômes yo ou ge doit pas jamais ge douleur, sou ge douleur c'est pas parce que c'est et cancer la ka bon douleur, c'est cancer la ge doit ka peser son l'autre organe qui est tellement grandi qu'a pesant l'autre organe qui doit bord douleur c'est pas principalement c'est pas cancer la qu'a bord douleur il dit peut-être dans stage 3 ou 4 gen moun peut-être on les cause ça gen symptômes et symptômes ça gen doit pas un symptôme qu'on t'a pas le cas docteur tout de suite c'est parce que ou gen doit gonti tous qui pas jamais aller ou gen doit sentir comme si on ti gens fatigué qui ou pas jamais sentir bon énergie ou gen doit ou perdre poids ou bien tousser les plus souvent ça que mène moun l'hôpital c'est tous qui viennent avec sang c'est ça que connaît qui était moun fait mon al ka docteur mais les plus souvent il dit en pile fois ou pas de symptômes du tout symptômes yo secondaires à un l'autre bagage c'est tumeur qui forcer peser en l'autre côté qui cause une infection il dit peut-être ou get ça que mène ka docteur parce que ouf gen infection dans poumon très souvent comme si ou gon flou en bronchitis on ba k'ap men ka docteur souvent qui fait yo ge doit venir faire une recherche pour yo ça k'ap cause li qui base là qui fait ou ge doit arriver et vinn détecter que peut-être ou gen cancer il dit que ge des fois c'est pas même fumer ge doit c'est quand on travail là qui cause cancer là soit travail en côté qui nan vieux ancien et appartement ou bien building qui te gen asbestos ou bien qui te gen arsenic li di peut gen tout gen moun toko qui ret nan et area qui gan pile construction moun qui ret en bas nan basement nan premier ou deuxième et floor yo moun sa yo at risque à un bagay qui les radon li di radon c'est un gaz invisible qui sont et on produit des construction ou bien peut-être ça que les y aurait les mining bah comme que j'ai dit ça en créole non I have to go look that up mais mining nan c'est là comme si mon ap et y a fait recherche dans terre les a digué dans terre y a une sorte de produit en gaz qui rete dans l'air là et c'est dans respirer et mode gaz ça yo qui doit ba ou et cancer là. Il dit que on monde qui fume un paquet cigarette chaque jour dans vie pour 20 ans qui dans l'âge de 50 à 80 ans supposé tester tout le temps chaque année pour cancer. Mais il dit parce que ces critères ça pour tester il fait trop rigide que l'autre monde qui pas vraiment fumer en pile ta doit tester aussi so il fait très dur pour tester monde qui doit éligible pour yo tester fait yo très difficile pour yo tester. So, si ou même, li do, li conseille yo, sou ou connaît, ou pas de kon fumer, mais ou te vive avec un monde qui fume. Mais ou fume, mais ou pas de fumer en pile, mais docteur la pas vle tester. So, ou docteur pas vle écouter ça dit parce que ou gen ti symptômes ici, ti symptômes l'autre bord, il dit changer docteur, cherchons l'autre. Continuer à advoquer pour tête ou en façon que pour continuer chercher, faire détecter pour qu'à connaître ça ou gen, pour qu'à traiter pi bonheur parce que j'en nous dis là, pi bonheur c'est grand matin. Okay, Brenneth, let's move forward, right?
Sure. Absolutely. What did you say you have to look up?
I had to look up mining.
Oh. Well, I mean, I say that because I am originally from Alaska, and Alaska has one of the highest rates of radon, which you wouldn't think since it's such a rural, state.
Ooh,
But it's
wow.
because of the high rates of mining. Yes.
Wow. So yes, I said I had to look up mining. How do you say mining in Creole?
Oh, mining. Gotcha.
Yes. So we're moving forward and we were talking about the power of early detection, and I kind of gave a short synopsis of what we covered so far up to that. Let's move forward with why screening guidelines need to improve. And I think you started touching on that very passionately.
Yeah. I am very passionate about that, actually. Yes. And I know that you mentioned, or you asked kind of early on, which I think I got sidetracked, but we specifically, I'd say, in terms of how the Black community, the Haitian community is affected versus really any other, racial group, in terms of statistics. And we know that Black men, and women are less likely to be diagnosed early. Really, I think the last statistic that I read was 13%, or 13% less likely to be diagnosed early. Really, how to explain that is that we know that if we catch it early, it's much easier to treat, right? We also know that this national data shows that Black and Haitian patients are often diagnosed at much later stages than white patients. If you think about this, like, catching a small leak, like a small roof leak, right? If you fix it right away, it's a simple job. If no one sees that leak until the roof falls in, the damage is severe. And too many people in all communities, but especially in the Black community, are only finding out after that roof has fallen in. In addition, we know that there is a significant surgical disparity, meaning that Black patients are about 19% less likely to receive curative surgical treatment when compared to white patients. And surgery to remove a tumor is one of the best ways to cure early stage cancer, especially lung cancer. And even so, statistics show that nearly 1 out of every 5 Black patients who could benefit from surgery does not get surgery. And I think there's a lot of reasons why this happens. It happens because of insurance roadblocks or access to specialized surgeons. Maybe, you don't live in an area where there's a specialized surgeon, or because doctors simply don't offer them all of the treatment options. And so it's another area where we need to be informed and we need to advocate for ourselves and understand treatment options and ask treatment options. I don't know any provider that would be, put out or would not be willing to answer your questions if you have questions about treatment, even if it's something that maybe isn't applicable to your disorder or disease. No provider that I know that is worth going to is going to say, "Oh, I won't even entertain that." Right? We're going to sit down. We're going to explain to you why this isn't maybe applicable for your situation, but maybe it's a misunderstanding. Maybe it's something that wasn't offered that should have been offered. Maybe that provider needs to take a second look. We as providers we are also flawed human beings as much as we try to be perfect in our, when we're treating patients. But a lot of times, if something is brought up by a patient, it will at least cause us to take a second look, and maybe we take a second look and say, no, this is my recommendation, or this is, you're not eligible for whatever it is, but feel good that you asked and always ask.
All right. I just want to share that tidbit. Betty, I want you to clarify. The
Sure.
survival rate is at a higher rate if it's surgically removed, correct?
So, yeah, I mean, surgery in itself is one of the best ways to cure early stage cancer. If you've got cancer that is still localized, right? So it's still only within the part of the body where it started. So lung cancer, it's in the lungs. It's it's nowhere else that we can see. Ideally, you would be able to just cut out that tumor. We do the same with many, many different types of cancer. Surgery is one of the best ways to cure that early stage cancer. Sometimes you need radiation to shrink that tumor to make it surgically eligible, or maybe you need, chemotherapy or immunotherapy, other treatment options to make that tumor smaller, so that then we think or then the surgeon thinks that they can go in and get it and get as much of it as possible, because even if one cell is left over after a surgical removal, that cell can then multiply and proliferate and can lead to spread of that disease. So you need to be confident as a surgeon, as an oncologist, as a provider, as a patient, that what you're treating, what you're taking out is it gives us the best chances of taking all of it as we can. And of course, that's better the smaller the tumor is. So yes, surgery to remove that tumor is one of the best ways to cure. Yet we know that nearly 1 out of every 5 Black patients who could benefit from surgery ends up not getting it. So 4 out of 5 are getting it. 1 out of 5, though, are not. And that's still a staggering statistic. And that's, I mean, if you think of I'm sure 10 men of those, 2 are not getting the treatment that they need, right? Like I said, this happens for many, many reasons, but we need to be our own advocate, or we need our loved ones to be our own advocates, to ask why. Maybe why wasn't surgery an option? Why wasn't I offered surgery? And maybe the answer is exactly what I was saying. Maybe the cancer has progressed, or the tumor is too large, or has too many roots, essentially, or too many kind of areas where we think it would be too difficult to get and go surgically remove. And so first you need treatment to shrink that tumor before surgery is even an option. But it never hurts to ask.
Okay. And as you stated before, and if you ask one provider and they're not open and or receptive, you just keep moving on to the next provider. Just keep asking.
I mean, if you go to a provider and ask a question and that provider just blows you off and doesn't give you any sort of answer, or you don't think adequately answers your question, or you just don't, we know in life that a lot of times certain personality traits, certain traits in general don't click with one another, and that's to no one's fault whatsoever, right? We can't all be best friends with one another. It's not your fault. It's not the provider's fault. But if you feel like you're not getting the care that you want, get a different provider. It's not, I think especially in the kind of older than 65 population, there is a huge not misconception, but there's a huge kind of just inherent belief that every doctor, every provider is going to give you the care that you want and the way that you want it. And regardless of what they say, that what they say is law, right? But again, we as providers are all human. We make mistakes. Unfortunately, I wish that we didn't. We make mistakes. We are pressed for time. We are, and so we also, again, don't click with everyone. And none of us would be offended if you said, I'm going to go get a second opinion. I'm going to go get, I'm going to go check out this other doctor, I mean, I'm going to go, I think of it almost like, dating. You want to find the person that is right for you so that you get the care that you want. Some people like a very direct, almost abrupt style of treatment. Some people don't want that at all. Some people, don't want to know every nuance. Some people do. So it's, I would say, not just specific to lung cancer, but to anything. You are not married to a provider. And if one provider isn't giving you what you want or what you need, go find someone that does. And maybe you get the same answer from 5 different people, and that's okay too. But maybe one of those says it in the way that you want it, or says it in a way that makes you understand it better.
Accept.
Well, yeah. And that in itself, I think, is worth it, because then going forward for the rest of your healthcare treatment, you're going to have somebody that's going to explain things in the way that you need it explained.
And in going into what you call the staging, like the different stages, can you just explain briefly the stages in itself?
Sure. I mean, not to get too, I guess, into
Technical.
the weeds,
Yep.
but yeah, I mean, staging really just measures how far the cancer has traveled in the body. So in terms of lung cancer, stages 1 and 2 mean that it's still localized inside the lung. Stage 3 means that it's reached nearby lymph nodes. And then stage 4 means that it's spread to other organs like the brain or the bones. And, we really worry about things like lymph nodes, because if you think of lymph nodes, it's almost like your plumbing system or your filtration system in the body. That once it's reached the lymph nodes, it's much easier for cancer to spread to other parts of the body. And that is when it gets way more difficult to treat. You can't go in and surgically remove any type of cancer from a bunch of different places throughout the body at once. And remember that all it takes is one tiny microscopic cell. And if you've got one cell somewhere, that's not going to show up on any scan until it gets big enough for us to see it. And technology is in a sci-fi era of how much we can see and how much we can detect. And we haven't even gotten into things like genetic testing, biomarker testing, to see if there are now special targeted medicines or immunotherapy that can block those specific genes that drive that cancer growth. But we know that if it's at that localized stage, meaning it's at that stage 1 or 2 and hasn't spread to the lymph nodes or to the rest of the body, it is much easier to treat. And again, that 5-year survival rate, right, at that localized stage was 65% of patients diagnosed with that early stage lung cancer. 65% were alive at 5 years. Those later stages 3 and 4, that number drops to less than 10%.
And I know we touched on treatment, and without getting in the thick of things of that as well, you talked about surgical removal at stage 1 and 2. Stage 3 and 4, what would be the treatment modality?
Well, again, it depends very much on where those tumors are located, how extensive the spread, how, whether or not a surgeon feels like they can surgically remove, how much you think can be shrunk by things like systemic treatment, meaning treatment that goes throughout the entire body, things like chemotherapy or immunotherapy or those targeted medicines. It's all dependent on so many factors. That's when it gets very complicated, I would say. It also depends on the type of lung cancer. There's a couple different types there's many types of lung cancer if you get into the genetic factors, but really there's 2 main types of lung cancer. Those non-small cell lung cancer and small cell lung cancer. And
talk about those.
So it's all dependent on all of those factors.
Let's touch those 2 lung cancer, the most common ones.
In terms of what, sure. So there's 2 main types of lung cancer, right? There's small cell and non-small cell. And small cell lung cancer includes really it includes small cell carcinoma and combined small cell carcinoma, which that just has to do with how those cells look under a microscope. But know that small cell makes up about 10 to 15% of all types of lung cancer. It's heavily linked to smoking. It's much more aggressive. It spreads very quickly, often to the brain, to the liver, and to the bones. And it's usually treated with things like chemo and radiation therapy versus surgery. And that's because of that tendency to spread to the other areas of the body, right? So you need that chemotherapy or systemic treatment or radiation therapy to shrink those tumors, because you can't surgically remove many tumors all around the body. That other type, right, the non-small cell lung cancer, makes up about 80 to 85% of cases. And within that, you've got a couple different subtypes. Adenocarcinoma is the most common. That's linked to specific mutations. And we know that many patients with non-small cell lung cancer are diagnosed late when the cancer's already spread. And we've already said this many times, but I will say it 1,000 more, that we know that once that cancer is already spread, it's much, much harder to treat. And again, the later the stage of diagnosis, the lower the chances of survival.
Wow. So who knew they were broken down in such small?
Oh, there's so much. Yeah.
Yeah, small entities of themselves. Wow.
Yeah. Really, just know that there are two main types. I would say small cell and non-small cell, and of those two, small cells is the more aggressive. And really, in the last 5 years, I'd say we've made huge leaps in how much we can treat and what we can treat in terms of things like targeted therapy. But that's when things like genetic testing comes into play, because once we figure out, these kind of genetic drivers behind lung cancer, we can then treat those specific genetic alterations with targeted therapy.
So now I remember when we did prostate, we talked about genetic therapy and how there were some specific testings for prostate. Are there any particular ones for lung cancer?
Absolutely.
Ooh,
so
talk
once
about
you've got
those.
a diagnosis, I know.
So
Once you've got a
excited.
diagnosis, it is. It's very, again, I think I said this in prostate cancer too, where it's not only fascinating to me, but it blows my mind almost how far we've come in such a short period of time with technology, really since we've, mapped the genome to know that certain mutations in certain cells lead to an increased risk for cancer. And we can now identify not only those cells or those mutations within the cells, but we know if you have that, it's linked to this type of lung cancer. So one of the most common, I would say, mutations that is linked to non-small cell lung cancer is what's called EGFR. That makes up about like 30 to 35% of all mutations within those patients with non-small cell lung cancer. But we have at least probably 10 to 20 additional driver mutations in that non-small cell lung cancer space that not only have been identified, but have specific targeted treatment. So once you're diagnosed with lung cancer and we determine, whether or not it's non-small cell or small cell, then we go further, make sure that you've got comprehensive genetic testing. And then once we identify what mutation is leading to that cancer, we can then treat that specific mutation.
So the EGFR is what's going to tell us what the mutation is.
The EGFR is the mutation itself, essentially.
Okay.
It's it's hard almost to explain without I want to draw you a map, but if you if you think about essentially a gene, right? We know that within those genes, you've got certain proteins that should be aligned in a certain way. And if one of those proteins is aligned incorrectly, it can lead to many different things. I mean, these are proteins that make up our genetic makeup, from, why your eyes are brown or why your hair color is one way. And this is also true in terms of cancers. We know there are certain mutations within those cells that are the drivers for creation of that tumor. They're the things that lead to these cells changing in a bad way, leading to cancer. And once we identify where that breakdown in the process is, we now have targeted therapy that goes in and stops that breakage, or stops that creation of that cell at the source.
Okay.
I know that was, yeah. It's hard to describe. I'll draw you a picture next time I see you. But yes, it's I don't know. I think it's absolutely fascinating. Not only do we know the patient's type of cancer, lung, we know the type of lung cancer, whether it's small cell or non-small cell. We know the gene that is affected, that EGFR gene. But then even going further, we know that it's the location on that gene, whether it's we call them exons. It's just talks about the placement on on that EGFR gene. So we know, exon 19, exon 20. We know where that gene is that's affected, and then we know the type of mutation on that gene. So you can have insertion, deletion, et cetera. And whether or not what the answer is to all of those questions not only leads us to know what your symptoms may be, or whether or not you're going to have more of a chance to get things like brain metastasis, lung metastasis, that kind of thing, or whether or not you have additional symptoms, where you would have those symptoms, what parts of your body would be more affected. That EGFR gene that we talked about, we express EGFR. So those EGFR cells are expressed in many, many places in our body, including the skin. So that also helps us when we're treating patients, if it's that kind of targeted therapy and we know the gene that's affected and then the gene that we are treating, we know that it makes it more predictable in terms of side effects when we're giving treatment.
Okay. Interesting. So you're able to predict metastasis, the symptoms, and side effects.
Yeah, and side effects of treatment, because we know what's being affected, and we know, that a lot of times, especially not just in targeted therapy, well, especially in things like chemotherapy, which, don't discriminate. They kill all
cells,
both healthy and unhealthy cells, right? Chemotherapy itself really just attacks rapidly dividing cells. So any cells in your body that rapidly divide, and think of things like the cells in our GI tract and our gastrointestinal tract, are some of those that rapidly divide at a higher rate than almost any other cell in our body. But we know
why they
that when
have
you
so
get
much nausea, diarrhea during those treatments.
Exactly, because that chemotherapy is blasting not just those unhealthy cells, but also those healthy cells that are rapidly dividing. Once we get to targeted therapy, because we know, not only what that gene or what that gene or that driver is, we also know that it's affecting that gene. I mean, EGFR stands for epidermal growth factor receptor. All that means is, if you've ever heard of the epidermis, or the
skin.
That's the skin, right? So we know that with targeted therapies that affect this EGFR gene, that you're going to have some skin
issues,
side effects. Yeah, because it's going to affect everywhere that EGFR gene is.
Makes a lot of sense when you break it down.
we're getting very much into now the cellular the cellular genetics of it, and again, it's fascinating, and it's fascinating just how far we've come in such a short period of time. But we could come so much farther.
I hear you. So now we want to talk about more about overcoming some of the cultural barriers that would prevent diagnoses, treatment, all that good stuff.
Absolutely. I mean, we know, we said Black patients are more likely to receive no medical treatment at all, or, less treatment, less curative treatment, especially compared to their white counterparts. I think even after receiving a lung cancer diagnosis, research reveals that Black patients are more likely to receive no treatment at all, meaning no surgery, no chemotherapy, no targeted medicine. And again, I think it's very multifactorial. It's due to fear. It's due to those high out-of-pocket costs. It's due to language gaps. It's due to that feeling overwhelmed by, the complicated medical system, or maybe lack of trust with the medical system. And we also have a big disparity in things like research studies. And it's, we don't have enough diversity in our clinical trials. And because of that, and we haven't, this is something that I'd say is still such a huge, huge problem today. And I know or can see why it would be a problem because of this huge mistrust of the medical system, right? But know also that our genetic makeup can change how a medication, or how well tolerated a medication is, or how well that medication works. And if that medication was only ever tested in one population, then we don't really know how it's going to work across every population. We're finding out now that medications we've been using for decades or even centuries work differently and may have less effectiveness in other racial groups. And that's because when we did clinical trials initially, or hundred years ago, that was not a diverse clinical trial that was adequately representing, all racial groups.
All ethnics. Mm-hmm.
Absolutely. So these are things that we're just finding today. I work for Johnson & Johnson. It's one of the biggest global healthcare companies in the world, right? And I look at some of our research studies today coming out, results of today, and we still have, whether it's a Black population, Asian population, we have numbers that are staggeringly low in our research trials. And so we have an entire section of our company that is dedicated. It's called Research Includes Me, but it's dedicated to just educating the population on why it's so important to be a part of a clinical trial. And I get not wanting to be a part of the clinical trial, especially if you don't really trust the healthcare system. And historically, yes, I get why you wouldn't trust the healthcare system, but also know that the more that we, as diverse groups, are represented in clinical trials, the more we're going to know what works best for you and be able to adequately treat whatever it is that we're treating, whether it's lung cancer or, or something, or high blood pressure, or, even things that we've been treating forever and we know have a good amount of treatment options. We could always do better.
For sure.
I don't mean to go on a tangent there about
No
research,
tangent.
but
No
it's
tangent, but
important.
sometimes I think it's good for the public to know how some of the treatments come about and how important it is for them to do their part. So that if you are part of that clinical trial, you are essentially maybe supporting the treatment or curing the treatment for a loved one down the future, your mom, your dad, your grandchild, your daughter, your son, someone in the future that may
Absolutely.
need it. So you're ultimately not maybe not saving you, but you're saving someone else who you may love dearly, who you would expect to want to live a lot longer if possible. If you had a hand in that,
Absolutely.
you get to say, it's because of me, you know?
Absolutely. I mean, and that's, clinical trials, depending on where they are and in what stage, there's lots of different stages of clinical trials and when and how something comes to market. But yes, it's sometimes those clinical trials may directly benefit you. Sometimes they may not. But yes, they will absolutely lead to or have the purpose of leading to more knowledge, more data in the future that can lead to something that might save your child, save your child's child, save your grandchild, save someone that you love and care about, or someone that you don't love and care about, but it might save someone.
Well, I guess we can't
and
pick and choose who it saves, but
right. Yes. I mean, but again, we talked about genetic factors, right? If you've got lung cancer, then that doubles the risk that any one of your,
future
that's
children,
related to
grandchildren,
you,
yep, are also at
is going to
risk.
get it. Yep, absolutely.
So, how
So,
about community support and empowerment? How would that look like these days?
I mean, we know, we absolutely know for a fact that, that patients who come in that have that are diagnosed with cancer that have social support will have better outcomes than those without social support. That is an absolute fact. And that cancer diagnosis, no one should face alone. And having a family and community support does so many things, including just reducing fear, reducing isolation, and bringing a trusted person with you to your appointments, making sure that you or they are writing down your questions, and knowing that you have a right to clear answers really should empower you to create that circle of trust, whether it's, your family, your friends, your spirituality, so your church, your groups like Hana are doing an amazing, building an amazing community. It just makes it, if you have that community support, it makes it so much easier to take action and stay consistent. And we know that when you're in that room, in that office, and you get that diagnosis, whether it's the big C word, whether it's cancer or it's something else equally, or any diagnosis, especially chronic diagnosis, or is devastating. And we know that you almost don't hear anything after that diagnosis, right? So having someone there to listen, having someone there to hear the information, in addition to you hearing it, right? You might be sitting there in that office and think, yes, I completely understand all of this. And then you walk away and go, wow, I don't remember a thing that she said. Or it just leads to such better outcomes, and feeling like you have support is like, it's an immeasurable amount of help with your overall treatment.
Absolutely. And I usually encourage my patients when they are coming, like if I have to, when I used to make those calls and say, hey, the doctor really needs to talk to you about your lab tests or the imaging that you got. And I really stress, like, don't come alone.
Absolutely.
Bring your husband, bring your
Absolutely.
daughter. If they have a language barrier, I tell them to bring someone who speaks English well, that
Yes.
can
Yes.
translate, so they're not relying on the translation line, because I hate the translation line.
We all do. We all do. I know.
I don't speak Spanish, and I correct their Spanish a lot of times. Like,
I
nope,
know.
that's not what I said.
Yes. Or it's a patient will answer and it'll be like 15 sentences, and
Yes,
then the
they
translator
gave
says
me 2
yes.
words. Nope,
Yeah.
that's not what they said.
I know that's not what they said. Yes.
Yeah, especially in our Spanish community,
it's
they're very good at giving very long stories, and I want every nitty gritty in there.
absolutely,
But
absolutely, because you never know what little pearl is in there that's going to lead to, down another line of questioning.
I
But
mean, not to go off topic, but I remember the first time I encountered a patient who spoke Spanish that refused to use the language line with me. And like she said, no, no, no. Like she just kept on saying no language line. And I literally was on Google Translate the whole time.
Yep.
Going back and
Yes.
forth. But it taught me key words that has stuck with me in my triaging forever. So even if I
Absolutely.
don't speak Spanish, I definitely can triage my patient. I can get the gist of their pain level, past surgical history and medical history, and be able to put that down in my note and confidently know that I'm relaying enough. So the doctor can mess with the translation line, but I'm out.
It's funny, right? I mean, and so often we're placed under these organizational barriers too. That even if you are Spanish speaking, even if Spanish is your first language, or you know whatever is your not English is your first language, they don't allow us to translate. We still have to use the translator.
Correct.
Uh,
So you can
and
communicate with the patient directly, but I
yes,
cannot translate on the patient's behalf or the provider's behalf because I'm not a certified translator. So I literally have to
exactly.
go to some special training to become a special trained translator for my language.
Right, which I always
It's
thought was so
dumb.
ridiculous. I mean, I never had to go to a course that made, that proved that I could speak English, right?
Correct.
But like I can't tell you how many countless people that I've worked with that were, especially Spanish, right?
Mm-hmm.
Just nature of where we live, that were Spanish was their first language, and they're making them go and have to prove that they can speak Spanish, and it's
It's
what is
it's
this?
absolutely dumb. But that's my
It's
soapbox.
silly. It's yes, exactly. I get it. I totally get it. But yeah, so what can you in the community, or what can listeners in the community do to help kind of support that all of these barriers that we spoke about? We know that especially I think in people in the Haitian community, in the Black community, feel like talking about smoking, talking about illness can be perceived as weakness. And maybe there's even some fear or some shame about smoking, right?
I don't
Or
know
maybe
if
they've had
it's
some bad.
shame, but it's like smoking itself is not shame for them. I think talking about their illness is like private. It's my business and no one
Yeah.
else's. It's between me and my doctor, and that's it. Like no
Yeah.
one else needs to know. So sometimes they are undergoing such horrific situations, treatment and cancer and all that stuff, and they're basically doing it alone. Or
Right.
like they only let one person in, and it's like it's hush hush. You tell anyone, it's
Yes.
like the Gustavo of the mafias, and they're coming out
Yeah.
to get you.
And what a shame, not only to place that burden, I don't mean burden, but to place that responsibility, I would say, on, just one person, whether it's your loved one, but also, and I heard this put, I think the best way I've heard it put is when you have a good friend or a loved one or whoever it is that was diagnosed with something and didn't tell you.
Mm-hmm.
I had an experience where I overheard a loved one say, "How dare you not share that with me and give me the privilege of supporting you through this?"
Mm-hmm.
Why is that? I understand it was your decision to not include me, but it would be my honor and privilege to support you through this. And if you're only allowing one person in, we see it all the time with things like caregiver fatigue, right? That one person then has this huge responsibility on their shoulders and also feels like they're restricted and themselves can't get any support or social support that they need because it's going to affect them as well.
I also
And the more
believe
people
that
Go ahead,
your
yeah.
providers give you like an abundance of care, knowing that you have a lot of hands supporting you. Like I can honestly tell you, my uncle just went through prostate cancer treatment, and although I couldn't call his providers all day every day, but my cousin who's an NP in North Carolina, he called in between his patients every day, all day. And then my uncle told him, he goes, I've got two doctors, my niece
Yeah.
and my nephew. I am not a doctor.
Yeah.
But he told them, don't let them come get you. I'm their favorite uncle. So he
Yeah.
knew that by any means necessary, these crazy Haitians are coming to get me. I got to do everything in my power for this guy.
Well, and what love and support, right? He must have felt in having not just a doctor or provider, whoever it is that's treating them, but also someone who could, listen to the same information, who could ask questions that he might not have thought about,
Make suggestions.
and that can. What's that?
Make suggestions, because my cousin looked up.
Absolutely.
He's in the cardiology, but he looked up every other treatment.
Yeah. Right, though, because again, it's so much easier for the person who is not the patient to hear that information and synthesize it in their, and really take it in, because you don't have that shock factor. You don't have that, all of the this is happening to me that is in your brain, right? But you have another set of ears and eyes and hands for you, and that ultimately just leads to so much better care, and so much help for patients, for healthcare providers, for everyone, I think, involved. But we know leads to better outcomes.
Yeah, and
So
I think that's the
you know-
time that, all the hush hush stories about, so and so in the family had cancer. Like, that's when it's all coming out. I'm like, well, I'm not hiding it. I was told. So had cancer.
And
so you need to know, because you're a guy. I don't have prostate, but you do.
But it also, and we learned this, right? We have genetic factors. So telling your family especially, but telling your loved ones might not lead to a difference in your care, but it might lead to a difference in whether or not someone gets tested early and gets their cancer found early. I can't tell you, especially in the case of things like prostate cancer, directly related to breast cancer, we know these genetic factors exist, and all I mean by genetic is that they're passed down, through your family.
gene,
So they're going to potentially affect your children, your siblings, your parents, and by speaking up, you may save their lives.
Yes. And resources. What kind of resources are out there for the community?
Yeah, there's a lot of good resources. I would say, for those of you who are listening and have either a loved one or yourself who has been diagnosed with something like lung cancer, I always caution patients on things like message boards, because I think that people who are going on message boards are only reporting the extremes, whether they're, I only ate cabbage for a month and my cancer's gone, or I had the worst possible experience on this drug and now I am, it's what created much worse of symptoms.
Things, yeah.
So
and everybody's
when
genetics
you're going-
is different, right? So I tell my patients each treatment treats each person individually different. So do not compare yourself to the next person.
Absolutely. Yes, there's so many factors we know and so many factors we don't know that go into how a treatment will work and how and what it will treat, what symptoms you'll have, etc. But you can definitely visit, the great places to start are things like the American Cancer Society website, the American Lung Association. These sites really explain not just screening, I'd say in pretty plain language. They also have tools that can help you decide, if you qualify for things like screening. You want to make sure that you are talking to your provider about and being very honest with yourself and them about your smoking history or any new symptoms. We want to, as a community, we really want to normalize these conversations. You can, start these conversations gently, and then maybe offer to go with someone to the doctor. We need to normalize just health checkups, those preventative checkups that were placed on hold for so long because of things like COVID. But know that you can go to these kind of trusted websites. You can utilize trusted organizations like Hana, like your community, because they already have trust. They can explain to you in, whether it's in Creole, whether it's in Spanish, whatnot. Go to your community, seek resources at your, whether it's a community center, your church, you would be surprised, I think, once you start sharing your story, how many people around you are dealing with something similar or have a friend who's dealing with something similar, or, we need to normalize all of these things. And we do that by talking and sharing stories.
All right. We're going to take a quick commercial break and we'll be right back.
Great.
Ou getan jouen nouvel la, an pa ou bien roule kounye. M'te dou sa. Chris Oro Hyper, une solution pour tout problème machine ou à ba ou. C'est problème mécanique, électrique et électrique. C'est qualité service nous baillons qui fait nous toujours été numéro 1. Visitez-nous une seule fois ou pas regret. Dans Chris Oro Hyper, nous ranger n'importe quelle machine. Côté problème nan yé, n'a détecté avec des appareils de dernier cri et un staff professionnel très accueillant. Bel local, bel parking. Et nous avons une qui pourra chercher machine ou mais n'elle vient joindre Chris. Nous avons pi bon service à pi bas prix. Diagnostic, AC, heating service, tires, nous changer, nous ranger. Brake service, oil change. Nous répile moteur, nous réparer transmission et la trier. Chris Auto Hyper ouvre porte lundi pour le samedi, 8h AM ou 7h PM. Visitez-nous, adresse 46 Grove Street, Spring Valley, New York, 10977. Contact 845 262 11 99. 845 262 11 99. Chris Auto Hyper, the best. Bienvenue à Size Restaurant, le meilleur restaurant haïtien à Nyack, New York. Vous voulez reprendre une bonjour pendant chita dans un bel espace, dans une atmosphère très accueillante. Une équipe professionnelle qui permet de sélectionner toute qualité plat haïtien, bien élaboré par des chefs. Size Restaurant and Lounge. Pas de pression, pas de tension. Venez découvrir la délicieuse cuisine de Size. Grillot, fritaille, légumes, cabri, du riz toute qualité, bon lambi, ragoût, poisson, maïs et latrier. Un menu qui est toujours chargé, bien présenté pour satisfaire tout client. Size Restaurant and Lounge ouvri mardi, mercredi, midi jusqu'à 8h du soir. Jeudi, 8h jusqu'à 10h du soir. Vendredi, samedi, 3h PM jusqu'à 2h30 du matin. Et le dimanche, midi jusqu'à 8h du soir. Size, c'est seul restaurant qui a bien mangé, emporté et puis sans caisse sautée. Visitez Size Restaurant and Lounge et découvrir toutes meilleures saveurs dans Caraïbes. Adresse 37 route 59 101A Nyack, New York. Téléphone 845 272 2014. Size Restaurant and Lounge. Venez affamés, repartez satisfaits et goûtez au cœur d'Haïti.
Welcome to Food Fair.
Food Fair, c'est un market qui l'a pour servir toute communauté. Yo vend bi bon produit dans bi bon prix. Pas rentrer la caillou sans pas passer acheter dans Food Fair. C'est eux qui pi bon et c'est là on joue tout produit qui sorti dans pays tant que Guatemala, Colombie, Mexique, Santo Domingo, Haïti, États-Unis, Équateur, Pérou pour ne citer ça seulement. Pour acheter sans besoin en gros ou en détail. Et puis, il y a un bicri kabao. Bon gâteau, bon petit plat chaud que vous pouvez manger en dedans ou bien l'arrivée la caillou. Relais au Kounia dans 845 290 06 25 ou bien passer dans l'adresse 175 East Central Avenue, Spring Valley, New York. Food Fair, c'est numéro 1.
Chaque Chaque mercredi, sorti 6h pour arriver 8h du soir, Hana, Asian American Nurses Association of Hudson Valley, New York, a invité à suivre une belle émission qui relève Health and Wellness sur Radio Groove FM. Dans l'émission ça, nous pourrons parler de la santé, nous pourrons parler de toute qualité maladie qu'on a gagné et bon conseil qu'on mérite. Pour participer avec nous dans belle émission ça, Health and Wellness, relève 845 419 1825 ou qu'abré chez nous sur App Radio qui c'est Groove FM Radio, sur Tuning, sur Groove FM Radio et sur 87.9 FM. Health and Wellness chaque mercredi 6h 8h du soir sur Radio Groove FM. Nous c'est Hana, santé ou c'est priorité nous.
Hana pas jamais découragé, Hana t'es campé pilité contre COVID-19.
And we are back. So, Brent, I'm going to give another quick recap of what we discussed when we came back from our last break. And then we'll
Great.
probably round out the show. Is that okay?
Sounds great.
Okay. So, Brent dit nous comme ça que et moun qui est ge famille qui te ge l'autre cancer, tokou maman, papa, soeur, frère, ou ge double chance pour ge cancer de poumon. OK? Il dit que sous te fait on l'autre cancer, donc ou fi te fait cancer dans sein et ou te prend traitement radiation, traitement ça tout ge doit mettre à double chance risque pour ge cancer de poumon aussi. OK? Il dit cancer de poumon ge 4 stages. OK? Premier et deuxième stage là, c'est plus bon stage là parce que et cancer là un petit peu petit, li principalement dans poumon simplement et li facile à traiter. Mais depuis dans stage 3 et 4, stage là li plus difficile à traiter. Dans stage 3, li dans partie qui est les lymph nodes. Lymph nodes c'est on sort de vaisseau tokou veine avec artère, mais lui-même c'est lui qui fait proptage dans sang, c'est lui qui retire toute impurité yo pour retirer dans sang depuis rive dans stage, li rive dans lymph nodes, li facile à transmettre l'autre côté dans corps. OK, dans stage 4, ça veut dire que li nan moelle tête, li nan zo, li pa di gaye tout partout dans corps. OK? Li dit depuis ou ka traiter dans stage 1 à 2, 65% moun qui gagne là les yo traité, yo survivre 5 ans, plus que 5 ans après ou te traité. Les ou dans stage 3 et 4, parce que les plusieurs côtés, faut que yo traite à plus médicaments. Ça dépend dans qui type de cancer gagne, docteur a toujours bon conseil dans qui ça cap mieux pour traiter li, mais ou doit servir à chimiothérapie, immunothérapie ou bien radiation. OK? Il dit que 2 formes de cancer de poumon qui pi prominent. OK? Que small cell cancer and non-small cell cancer. Il dit ça que small cell cancer c'est li pi agressif là. Li ka gaye tout partout dans moelle tête ou dans zo, c'est la plus souvent c'est radiation à chimiothérapie qui traite ça. OK? Li c'est li pi mal dans tous les deux. OK? The non-small cancer, li dit 80-85% moun c'est cancer ça yo gagné, li plus souvent yo connaît l'adenocarcinoma et li gon spécial mutation la donné qui pi comment la donne. Li dit Jean pour ta connaît qui mutation. Chaque cancer yo gagné, c'est pas genetic testing, c'est là fin assurer qu'on a cancer kounya y a fait genetic testing pour test les tester pour genetic testing nan li le EGFR. OK, c'est les pi comment que yo servi test ça pour dire qui sort de cancer ou gain. La pour dire exactement les qui sort de cancer gain, qui jan yo ka traiter, qui jan symptômes ou à pied. OK, qui si cancer a gain pour gayer, qui bol ap gayer et yo doit même dire qui sort de symptômes ou ap gain là yo commencer traiter. C'est ça qui fait très important. Puis bonheur c'est grand matin pour chercher un docteur sous des symptômes, sous pas des symptômes, sous une histoire de fumée, sous une histoire de vive à moun qui te kon fume. Ou bien te kon travay nan ancien et structure tokou ancien building ou sou li te mentionne un bagay talè an pat mentionne li, moun ki te viv prè à 9/11 ou bien ki te travailleur nan proptage 9/11 nan, tout moun sa yo a risque à cancer. So très important ko get tested ou chercher traitement avec et screenings. Okay, Brenneth?
Yep, still here.
Awesome. Perfect. So in wrapping up as best as we can, right? I wrapped up that the different stages, the 1 and 2, the 3 and 4, and how localized 1 and 2 is. 3 and 4 is more goes to the lymph nodes, brain, bone, and so forth, and how the treatments and modality are different for the different stages. The difference between small cell carcinoma and the non-small cell, and the genetic testing. Anything else you wanted to add to that?
Oh, we talked a bit about those resources, just making sure that if you do have any questions about screening decisions, or for anyone that's listening that wants to take action today, you can go to that American Cancer Society website, to the American Lung Association. There's also a handful of great organizations that are doing fantastic work on lung cancer research, like the Lung Cancer Research Foundation, LCRF. Longevity is also a big one. We at Johnson & Johnson have a website called Be Lung Here, which is for patients, for not just patients, but really anyone touched by lung cancer, whether it's patients or their loved ones or their friends or et cetera. There's also Go2 for lung cancer, which has some great navigation tools and screening location finders. And so, exploring those sites, reading, they all explain screening in very plain language. They have tools that can even help you decide whether or not you qualify for screening. And then again, remember that if you are outside of those screening guideline, outside of that screening guideline criteria, you can still ask about screening. And maybe you do have a symptom or a family history or something that that would cause you to get screened, even though you don't meet that criteria of being, you're 50 to 80, you've had 20 pack years of smoking, you're a current smoker, or you've quit within the last 15 years. So, you might have accumulation of risk factors that are outside of those that would still mean that we would screen you for lung cancer. And so knowing your smoking history, knowing whether or not you have lung cancer in your family, knowing your occupational exposure, so whether or not you were exposed to any of those chemicals like radon or asbestos or arsenic, and then being your own advocate and talking to your doctor about getting a low-dose CT scan, or whether or not you're eligible for screening. And especially don't wait until you feel sick or until you start coughing. If you meet that screening criteria or you have any of those risk factors, make sure you bring it up with your healthcare provider. And if you have a loved one that meets those screening criteria or has one of those risk factors, advocate for them, talk to them, try to normalize these conversations in your community, and don't wait.
Now, we talked about almost everything, but we didn't mention what the screening tests were. Brenneth, oh my God, quel faux pas. Think I caught it early.
Yes, I mean ultimately it's a low dose CT scan, and we mentioned it I think early on, but I didn't go into what that is. But it's a CAT scan that has low dose radiation essentially, and so a lot of people I think of lung cancer screening like, oh, it's just an X-ray, but X-rays don't give us enough of an actual look at the lungs, and especially, doesn't take CT scans take almost like slices of the lung, so you can see the lung. I always think of it as like an X-ray shows you just like if you were to look at the outside of a house, it just shows you a picture of a house, whereas a CAT scan will show you what all the rooms look like and what the blueprint looks like. And and that's the importance. We need to see at a microscopic level whether or not you have any of these malformed cells. But unlike a regular CT scan, really the only difference is that it's got less radiation. It's still very easy test, but it's an expensive test to our insurance companies, and especially to those who don't have insurance. And so that can be such a barrier. But there are great community organizations. I mean, I know that there are organizations throughout different healthcare systems. The one I'm most familiar with would be Montefiore. Montefiore has what's called the BOLD program, and that stands for the Bronx Oncology Living Daily. It's specific to the Bronx, but they have tons of resources that can be and the people who run that program are amazing and could probably, if you were outside of the Bronx, you can find them. I know for a fact that they would help you find resources in your community to make screening more available to you. But
and how often would an individual who does fall into the criteria, how often would they have their screenings? Is it annually, every 2 years?
Yep. It's yearly. It's yearly. And then of course that the amount of screening, like if you did have something suspicious, maybe that wasn't confirmed, it's the same as almost any other screening test. If if you have something that's suspicious but maybe doesn't fully look like cancer, we might have you come back sooner to get screened again, sooner than annually. But yes, those are the guidelines. If you fall within that screening criteria, we're going to screen you annually with that low dose CT scan.
Awesome. Perfect. So thank you so much, Brenneth. It was a wealth of knowledge, but tell the people that you'll be here for the Hana Health and Wellness Health Fair in August.
Yep.
And you'll have all these great pamphlets and information, and you'll be readily accessible to answer questions. Tell them.
I will be readily accessible. I'll have whatever printed information that I can have. I will have it.
Tell them we're here not just to have you on the radio, hear that wonderful melodious voice of yours, but you'll be in the flesh.
Yes, come meet me in person. Come out to the health fair. It's amazing. So many great resources and for so many areas. Yes.
Yeah, and I think usually we try to tie in Haiti into these underserved communities, but as you know, lung cancer is becoming an increasing public health concern in Haiti. Although Haiti reports lower lung cancer rates than the high-income countries, experts believe the true burden is likely underestimated because of the limited cancer registries, restricted access to diagnostic imaging, and fewer pathology services, tobacco use, secondhand smoke, indoor air pollution, and charcoal and biomass cooking fuels delay the diagnosis of all contribute to the disease burden. So many patients are diagnosed only when symptoms become severe and limiting, and treatments are very few. So we want to thank you for always coming to our dire call in educating our community.
My pleasure.
And we want to remind our audience that everything that was shared tonight is for your informational purpose only. If anything struck a nerve, a chord, something, please find your own provider. Go get specific questions for them so they can specifically treat and diagnose you, so that way you can come out ahead. So you can be here, as I tell my patients, you're here for a long time, not a fun time.
I like it. Yeah. Absolutely. Yeah. If something struck a nerve or a chord, that means that, there's a reason, right? There's some emotion tied behind it. So figure out what that is.
Something that triggered a memory, ask. I did have a few spouts of coughing up blood. I had a bad cold. Yeah. I chucked it up to the cold. Now it's probably the time to go check, right? Yep. Especially if you lived in a household like I did with a bunch of smokers.
Exactly. And yes, you're right. I get this, my last piece of I don't know, wisdom is that I get all the time. Well, I knew my grandmother lived until 100 and and smoked every day.
Yeah, my
Good for them.
grandfather lived to 80 something and he smoked every day.
Good for them. Good for them. That does not mean the same fate will befall us all. That's all.
Yes, because the genetic
yeah.
makeup is slightly different for each person.
Yep.
Remember, you get 36 and 36 of each mom and dad. So it's kind of
Yes, you are not them is
Yes.
the answer. Yeah. So,
So.
yes. But knowledge is power. Knowledge
It
is power, and
is.
asking questions is
It
key.
is.
And
So.
and really, in this life, we've got to be our own advocate.
Yes. So thank you for being on the show, and we look forward to your next show next month. So everyone who's listening, you didn't call in, and I didn't share the numbers as I should have, but I was so taken back by all the information I forgot to share. But please feel free to call, text me, Hannah. Everyone who knows my number has it, and everyone has Hannah's number. So text and call any questions. Brenneth will be on the show next month. We can always tap into her and ask more questions, and she will be here Saturday, August 8th, 10 to 2 at St. Joseph's Church. We will be there loud and free and here to give away vitals checks, nutrition and fitness info, mental health info, men's health info, women's health info, cancer info. Free giveaway and goodie bags will be available. We ask everyone to join us on August 8th, 10 to 2 at St. Joseph's Church. Tout moun nap Anna ap nan Saint-Joseph, 8 août. OK, de 10h à 2h pour un community health fair. Nap la pour nous checker tension, checker sucre, second question de n'importe question de santé ou gain, c'est juste ça pour venir. C'est pas juste les on nous fait un petit rencontre dans l'area. Ah miss nous tando sur radio t'a parlé, même te gen question ça pour venir dans health fair là, venir maman, venir soeur, venir frère, venir timounio parce que n'a get giveaway, n'a gon bouncy house, venir come. Everybody come one, come all, and Brenneth will be here to answer your cancer questions, all right?
So much fun.
Thank you, Brenneth. Have a great evening.
Thanks all. Always my pleasure.
My pleasure too. Bye.
Bye.
Radio Groove FM. On ne recommence pas. On continue. Nous sommes sur le 87.9 FM et sur www.radiogroovefm.com.
Bagay mbak jom panse, gade kon yam chanje. Se mwen Putin jom bak twe, se mwen Putin jom bak twe. Tout man de kon fe.